All right, now we got it. I am live. I'm going to share this out to Facebook. One second. Feel free to ask your questions in the chat. If you guys are on, let me know. I'm going to click the chat here. Ask your questions. While I'm waiting for you guys to ask your questions, there's 6 of you watching right now. What's kind of cool about Zoom is that I can share my screen. So hopefully you guys can hear me. You guys can see me okay. In fact, I'm going to try my camera real quick just to make sure. But I know there are a bunch of questions that came in through the Facebook group. I want to see if I can answer some. Hopefully you guys know. Let's see here. My camera. Okay, there we go. Looks like it's working. Got 10 of you on here. One of the questions that we were talking about recently was talking about going downstairs. And specifically, let me share my screen. Sandy was asking about going downstairs, doing a leg extension, leg press, kind of functional exercise in general. And so what I wanted to do was talk about it here just a little bit. So on the screen behind me, you can see a photo of an individual doing a leg press. And what I would tell you when you're thinking about exercises at the gym, now, obviously this is, 3 months, 6 months, 12 months down the road. We're looking at ways to increase muscle strength, improve performance. That's really the goal at this point. If you think of the knee angle, if you remember from when you were in therapy, they got a goniometer out, they measured knee range of motion. She is probably just a little bit more than 90 degrees. So in a leg press machine like this, and there's different versions, if you're doing a leg press, this is working the hamstring muscles, the muscles in the back of the leg. It's working the gluteal muscles, your butt muscles. It's working the quadriceps. It's working the calf muscle. It's working back extensors. So if you imagine that's about 90 pounds plus the weight of the carousel itself. So usually it's about 135 pounds, give or take. In order for her to generate the force through the legs of pushing that away, what she's also doing is pushing her back into the support of the seat. So she's working back extensors. She's working pretty much all of what we'd consider a posterior chain, along with some anterior chain muscles. Compare this to, I'm going to come to this picture here in just a second, to this picture. So in this picture, the individual is sitting down. They're kicking their legs straight. So if you look at the photo on the right, you can see that she's got 2 plates on there, probably about 20 or 30 pounds total. You divide that across both of the legs. So she's really only pushing about 15 pounds with each leg. And I would even tell you, take that a step further. If you look at the shape of the like the pulley system, this is a variable resistance machine. And basically what's happening is it's changing the resistance based on the angle of motion. So for somebody, a therapist, a personal trainer, a surgeon to say, don't do this exercise, without context, it doesn't really mean anything. If this young female, where'd she go, is pressing 135 pounds, and she probably doesn't weigh 135 pounds herself, compared to this individual who's doing 15 pounds on each leg. And if she had knee replacement on one side, she's probably using the other leg to do more of the work than the surgical side. Certainly you can do this single leg at a time. It's going to give you a better workout. But the idea with this is everything needs context. So why would somebody choose to do this exercise when functionally there's really no benefit? Now, full disclosure, I don't use this exercise to increase quadricep strength. I just don't. I don't think it's a very effective exercise. I'm going to use lunges, leg press, squat, body weight exercises. And then once we move beyond body weight exercises, I tend to take my clients to, again, more higher demand functional exercise. But that being said, even though I don't use this exercise, if you think of how this exercise works and you think of a functional movement like going down the stairs, I'll get to your questions in a second. I see them coming in. A leg extension at a low intensity, lightweight, might more closely replicate what you see happening on the screen behind me. And so if you think of a slow motion walking downstairs, this little motion right there, think of the support leg. That knee is over the toe. It's not a position that's typically strengthened. Now, there's a guy, knees over toes. He's got a lot of great content. But the idea is, if we want to improve function, if we want to improve your ability to walk downstairs, we do want to put the knee in some challenging positions. We want to control the loading and the resistance. We don't want to do it to the point that we cause more inflammation, more soreness, more pain, but we do want to do it in a way that taxes the system. There's something called an overload principle, where once the tissue is healed, once you've passed that 12 to 24-week mark, we do want to start working some of those tissues in a way that's not necessarily super comfortable. And so that's where you require the skills of a therapist. That's where you really need to be working with somebody that you can trust. Okay, so let's jump in. But full disclosure, I love squats. I love deadlift. I love lunges. Like, my preference for any patient at any level of recovery, from 1 week acute post-op through 12 months, is to focus on function. How can we most closely replicate the function that you need? If you can't get off the toilet, we're going to put the ankle, the knee, the hip in positions that simulate the same positions you would be in when you're sitting on the toilet trying to get back up. Okay, so we've got some questions coming in. Had a total knee replacement 14 months ago. My knee buckles laterally big time. Excuse me. I have to squeeze my quads to walk. Second opinion says torn LCL or stretched. He says a revision with a bigger prosthetic. Yeah, I've seen this before. We've had patients with ruptured either MCL. So the MCL is the ligament that runs on the inside. The LCL is the ligament that runs on the outside. Let me share my screen again, and I kind of like this. We could do some serious education here. No, you said LCL ligament. So if we look at the general structures of the knee, let me see if I can zoom in here a little bit. So you can see on the sides of the knee, the LCL is on the inside, or outside, the MCL is on the inside. If one of these structures was ruptured, which isn't that uncommon, what happens is the knee becomes really unstable. It can buckle to the outside because there's nothing holding the outside of the knee together. This image shows the LCL ruptured on the left. You see the fibula, which is that long skinny bone on the left. So that lateral instability, that's not really the kind of thing that you can probably fix without surgery. Braces never really do that good of a job. I've tried to use braces historically. We've used lots of different kinds of braces. If somebody just wasn't going to be a surgical candidate, maybe you can make a case for bracing. But I can tell you that if there's an opportunity to do a revision, to tighten up the lateral component, but keep in mind, if you do that, you're also going to lose range of motion. So if you're tightening up the joint and repairing or putting a larger implant there, you are going to lose some range of motion. So squatting is going to be more difficult. Flexion, extension might be limited in end ranges. There's going to be a price to pay there. but I've seen it. People have chosen to live with the instability. They've tried bracing it. I've seen people have the surgical repair and revision and do really well with that, but they were limited in their range of motion. And so appreciate your group. Should you continue exercise ROF, which I think it might be ROM, exercises after you achieve higher goals? 8 months, 0 and 120 range of motion. Randall, I'm a believer back to in function. I think range of motion is fine. But I know people who even without knee replacement, they don't have full range of motion, and functionally they're doing amazing. I've said it before. I'm going to say it again. I'd rather have a knee that is too tight than a knee that is too loose. Yes, we want the ideal. We want that, 120 to 135 flexion and full extension. But that being said, our bodies are incredibly adaptive. So I would focus on strength and function. That would be my goal, especially at 8 months like you are. That's where I'd be looking at what you want to achieve, you as an individual. That's why I can't prescribe programming, because everybody's different. So if somebody comes and they say they want to be able to walk on uneven terrain and hike trails, they're going to have a different program than somebody who says they want to garden in the backyard versus somebody who says, I want to lay out by the pool and, get a nice tan. Everybody has to have a program based on their particular goals. So, but yeah, I would focus on strength and function. I wouldn't get hung up on range of motion. Range of motion comes with strength and function. If your function is to get on the ground, your range of motion is going to improve to allow you to get on the ground, so range of motion is a byproduct. I don't think it should be the primary focus once you're past 12 weeks for sure. Even at 6 weeks, we pretty much get past range of motion by 6 weeks and focus on function. Is it normal to have a popping, grinding, and burning 6 months out? Just saw the surgeon. He said everything was fine. Wanted me to do 2 more months of aggressive therapy. So the question is, Kristen, what is causing the popping, grinding, burning? I've got some videos on the channel talking about a Velcro kind of sensation, depending on if they surface the bottom of the patella. So the grinding, I'm going to hit each of these 3 things. When you talk about grinding, that's most likely the bottom of the patella pressing against the implant, the prosthesis, whether it's an artificial surface or not, that could be causing some of that grinding sensation. Hydrating yourself might help. It might help. Making sure you have plenty of fluids, because the synovial fluid inside the joint helps to lubricate the surfaces. But outside of that, what I typically see is that as your body adapts to the implant, and 6 months is a good time frame, but probably closer to 12 months, as your body adapts, as your hip and ankle alignment change to accommodate the new knee, the grinding will probably go away. The popping, I'm not sure what would be causing the popping. I've got patients, and I've got them on video, where when they go to flex their knee, they get a popping sensation, and it's coming from the fibular head. The fibula is the bone on the outside. It runs down to the outside of the ankle, up to the side of the knee. And what happens is, as the tibia moves front to back when the knee is flexing and extending, there's a rotational component there. The knee replacement, most knee replacements don't have rotation. Some do. But the fibula, the top of that bone, will kind of move, and it'll pop back and forth with flexion extension. It's not painful, but it doesn't exactly feel good. Again, that's something that if you control the angle of the hip while you're moving or walking or squatting or doing the thing that makes it pop, sometimes you can stop or eliminate the popping sensation. So if I was to sit in a chair and then stand back up and my knee popped, I would try to keep my feet straight. I would try to move my knees wide and do the same motion, sit and stand. Maybe it pops, maybe it doesn't. If it still pops, then I would try to move my knee medially, turn my knee in, almost like you're bow-legged or knock-kneed. I would sit to stand. And if I can find a position that eliminates the popping, that means that it's a mechanical alignment issue that's causing the knee to pop. There are certain strategies you can use to mobilize the hip and the ankle to eliminate the popping at the knee. But my guess is it's probably the fibular head that's causing the popping. And then the burning, that's always hard. Is it a muscular burning? Is it a nerve sensation? When they cut through the tissue, they disrupt the lymphatic drainage and everything. It has a major impact. So there's a lot of things that could contribute to the burning. The massage with the rolling pin might help some of that. Activity might help some of that. I would also need to know, like, does the burning get worse with activity? Does it get better with activity? Does the burning stop when you stop moving? There's lots of components there. That's a great one for a physical therapist to look at and assess if they think it's a nerve problem or a circulatory vascular problem or something else that's going on. Rita, let's see, which has now turned painful? Any ideas? I missed the beginning of that. Sorry, Rita. Post again and I'll come back to it. My Josie said, my ortho changed me to a third physical therapist. Bending my knees too brutal, forceful. I scream. Is that right? I had an MUA. My bend is 100. Extension is -5. 5 months post-op. Yeah, Josie, unfortunately, you're not alone. There are a lot of individuals who really struggle with finding the right balance in a PT that allows them to continue to gain range of motion, continue to stimulate the tissue to produce a response, but not do so much that it sets you back. And so the overload principle, once again, applies to connective tissue that's part of your knee. If you do too little, it doesn't help. If you do too much, it doesn't help. You got to find Goldilocks right in the middle, just right. So it's hard. It's really, really difficult. I know even within my clinic, as much as I pride myself on trying to listen to my patient, trying to be the best therapist that I can be, I know that there's absolutely times that patients do better with other clinicians. And my ultimate responsibility as a therapist is to identify if I can't serve my individual patient what they need, I need to find them a therapist who can. And for some patients, that's a therapist who's going to push them harder. For other patients, it's a therapist who's going to take it slower. I don't know if you're switching within the same organization or if you're switching to different therapy groups, but I would tell you that the right therapist is absolutely out there. And if you want to, move a little more slowly, that's okay. Like, that's your prerogative. I can tell you that most of the patients who are in my clinic, when they're just really, really struggling and beating themselves up, they're the patients that are usually doing more than they should be doing. They're the patients that are usually pushing too hard, trying too hard, never giving their bodies a chance to recover. So throttling back on the intensity, even the most fit Olympic athlete can't do high-level activities every single day. They need the recovery. We get stronger when we're recovering and resting, not when we're working. The purpose of exercise is to break down the muscle fibers, the connective tissue. Then the purpose of resting is to allow it to repair longer, repair stronger. So if we're not getting adequate rest, and everybody's rest is different. Even for me, some days I can go work out harder and recover quicker. Other days I feel like I barely got a workout in and it takes me 3 days to recover from what I did. Your body's going to be dealing with stuff. If you have any immune issues going on, any other complexities, whether it be diabetes or hypertension or any of the other stuff that patients are typically dealing with, all of that is going to impact your recovery. I wouldn't focus on the work you put in. I would focus on your ability to recover. So guys, it's 4:29 my time. I hate to cut it short. I so appreciate you guys joining me live like this. And I really do want to try to continue to do more of these, just kind of impromptu. I had 20 minutes, got cut down a little bit because of technical issues. If you're not already a subscriber to the channel, please consider subscribing. The channel's reaching a lot of people. People are sharing the videos, which is so impactful, and I appreciate it so much. Otherwise, guys, thank you, and I'll see you on the next YouTube Live.